For opening remarks, my name is Nadim Aburustum. I'm the chief of the Gynecologic Oncology Service and the Avon Chair in Gynecologic Oncology in the Department of Surgery at Memorial Sloan Kettering Cancer Center. I'm also a professor of obstetrics and gynecology at the Weill Cornell Medical College. I serve as chair of the NCCN Cervical Uterine Cancer Panel, and I'm also a member of the JNCCN editorial board. I'm pleased to moderate this session on management of advanced ovarian, fallopian tube, and primary peritoneal cancers. At this time, I would like to introduce our speaker, Dr. Joyce Liu, is Associate Chief and Director of Clinical Research in the Division of Gynecologic Oncology at Dana-Farber Cancer Institute. She also serves as the Associate Clinical Research Officer for Dana-Farber Cancer Institute and is an Associate Professor of Medicine at Harvard Medical School. Dr. Liu currently serves on the NCCN Ovarian Cancer Panel. And now I'll turn it over to Dr. Liu for her presentation. Thank you, Joyce.
Thank you so much, Dr. Aburustum, for that very nice introduction, and thank you for all of us, all of you, both in person and virtually, for joining me today. I'd like to thank the NCCN for inviting me to talk about updates in the management of advanced ovarian, fallopian tube, and primary peritoneal cancers. Just a review of ovarian cancer now in 2023. In the US, about 19,000 plus cases are estimated to occur this year. This remains the second most common GYN cancer in the United States. Endometrial cancer is the most common, and there's about a 1.4% lifetime risk of developing ovarian cancer. Mortality in the US has been slowly improving. This is about 13,000 estimated deaths are guessed to occur in 2023, and ovarian cancer currently remains the fifth most common cause of cancer death in women in the US and the leading cause of GYN cancer death. That being said, it is changing. Endometrial cancer is right behind ovarian cancer, and it's projected in the coming years that endometrial cancer will overtake ovarian cancer as the leading cause of GYN cancer death for women in the United States. As you can see from the figure here to the right, the 5-year survival has been very modestly improving over time, and that has to do probably with some of the improvements and developments in our therapies for ovarian cancer, as I'll be sharing. There are a number of risk factors that are associated with ovarian cancer. We know that advanced age and family history, there was a great talk on hereditary ovarian cancer and breast cancer earlier today, are contributory. The increase in ovulation cycles, so nulliparity, increases risk. We know that estrogen replacement and talc powder have slightly increased associations with ovarian cancer, not so much that you can estimate and say that any individual developed ovarian cancer because of their use. Pelvic inflammatory disease, living in industrialized Western countries, or being of Jewish descent also are associated with an increased risk. On the opposite side, decreasing risk for ovarian cancer, things that decrease ovulation cycles, so lactation, oral contraceptives, having children, we know decreased risk. And then, of course, reproductive surgery, either tubal ligation or oophorectomy and hysterectomy. And I don't have here salpingectomy, but those we know are associated with decreased risk. A word about hereditary ovarian cancer. As I mentioned, there was a great session earlier today, so I'm not going to sort of talk about this extensively, but we've recognized hereditary mutations may contribute to ovarian cancer risk. The most commonly associated genes are BRCA1 and BRCA2. BRCA1 has about a 40% lifetime risk of ovarian cancer, BRCA2 about a 15% risk. And somewhere between 10 to 15% of ovarian cancers may have BRCA1 or BRCA2 mutations that are hereditary. Up to 40% of patients with germline BRCA1 or 2 mutations may not have a suggestive family history. And so that's why it's very, very important, and it is an absolute guideline, that all women with a diagnosis of epithelial ovarian cancer are recommended to have genetic counseling regarding germline BRCA testing. It has implications for their own care as well as for cascade testing amongst their family members. We think about ovarian cancers, but as we've known for over a decade now, the ovarian cancers may start, many of them, in the fallopian tube. And this is in the fimbriae of the fallopian tube. We know from surgeries that about 50% of cancers in women with BRCA mutation carriers who have prophylactic surgery. We can see the initial lesions in the fallopian tube. And research has shown that you can have this evolution from precursor lesions to invasive carcinoma. Starting here, you get a P53 signature, then you get a tubal intraepithelial carcinoma. You can see it's starting to become abnormal before it becomes a frank invasive carcinoma. There are trials now in progress to investigate whether you could remove just the fallopian tubes initially to prevent ovarian cancer in high-risk women with a delayed oophorectomy, thinking about the risks associated with early menopause. But I do want to say these are trials. The standard of care in the United States remains removal of both the oophorectomy and fallopian tubes at the time of surgery. So this is still something that we are understanding and testing. When we think about the various types of ovarian cancer, classically we've thought about these as by what they look like under the microscope. So these are the classic sort of serous, mucinous, endometrioid, clear cell histologies of ovarian cancer. Increasingly, we're recognizing that these are associated with different genomic characteristics. So for example, high-grade serous or endometrioid cancers are more associated with HR deficiency and inability to repair double-strand breaks in the DNA. Low-grade endometrioids have P10 and ARID1A and PIK3CA mutations. They may be more associated with microsatellite unstable status. Low-grade serous ovarian cancers have KRAS and BRAF mutations. Clear cells, again, have PIK3CA, ARID1A, P10 mutations, mucinous with KRAS mutations. And as you can see here, they have different clinical characteristics, and these molecular, their genomic characteristics, may actually affect how they respond to different therapies. Traditionally, we've thought about ovarian cancer as, one size fits all. We treat them with carboplatin and paclitaxel chemotherapy, but the world is changing as we understand more and more about the biology of these tumors. A word about DNA repair defects in high-grade serous ovarian cancers. So I've mentioned that these are the most common histology of ovarian cancer, and about 50% of these are what we call HR deficient, meaning they have that problem in repairing double-strand breaks of DNA. The most common causes of these are the BRCA1 and BRCA2 mutations. As I mentioned, 10 to 15% of patients with high-grade serous ovarian cancers will have a germline BRCA1 or 2 mutation, but importantly, you can see that we also get somatic mutations in these patients. So those are mutations that happen only in the tumor. They are not hereditary, but they still have implications for the care of the patient and how much they might benefit from PARP inhibitors. And so I would say that it's really important that we consider tumor molecular testing for all newly diagnosed ovarian cancers so that we can start thinking about how we best treat them. In terms of ovarian cancer staging, the FIGO staging was last updated in 2014. At that time, there were a few major updates compared to our priors. Stage 1C was divided into 3 subcategories by whether or not there was an intraoperative spill, whether or not the capsule had ruptured originally, or whether there was positive cytology. Stage 2 was divided into only 2 categories instead of 3, which we had previously had. Stage 3A was divided into 2 categories, one with 3A1, which is retroperitoneal lymph node involvement only, or stage 3A2, which was all other prior stage 3A cancers. And then finally recognizing that pleural effusions are maybe not exactly the same as hematogenous type metastatic events. Stage 4 was divided into 4A, which was cytology positive pleural effusions, and 4B, all other prior stage 4s. So now I want to move on and talk about, so how do we think about managing newly diagnosed advanced ovarian cancer now in 2023? And some of these basic principles have been true for many years and remain the same. It is really important that when we think about surgery, that we try and refer these patients to a gynecologic oncology surgeon. We have data that has gone back for many years showing that surgery by a GYN oncologist is associated with improved survival for our women with newly diagnosed advanced ovarian cancer. When we think about the extent of surgery, it's classified by the residual disease following surgery. There's suboptimal, which is there's greater than 1 centimeter of residual tumor, optimal, less than or equal to 1 centimeter of residual tumor, and then what we call NED or R0 resections, where there's no gross residual tumor, and that's what we always strive to get to. What are our considerations now in the approach to our initial disease treatment? You're seeing somebody new with advanced ovarian cancer. What do you think about? I think about what's the role of neoadjuvant chemotherapy? Is there, and what is the role of intraperitoneal chemotherapy? Do you add bevacizumab to that initial regimen? And do we do HR deficiency testing, so HRD testing, also called genomic instability testing? And what's the role of PARP inhibitor maintenance? And I'm going to go through those. So the first question is neoadjuvant chemotherapy. Somebody comes to see you, and are you going to give them chemotherapy first, or are they going to go to surgery first? And this was examined initially in 2 large phase 3 studies, one from Vergote and colleagues from the EORTC and the other from the CHORUS study, where patients were randomized to either get 3 cycles of initial chemotherapy, followed by surgery, followed by 3 additional cycles of chemotherapy, or to get surgery first, followed by 6 cycles of chemotherapy. And you can see this trial characteristics are summarized here. Most of the patients had stage 3C disease, about 3/4 of them. And in the results, you can see that the median progression-free survival was equivalent whether or not patients got chemotherapy first or surgery first, and the median overall survival was also about the same. There were more post-surgical sort of complications in patients who went to surgery initially compared to those who had neoadjuvant chemotherapy. Importantly, we have to remember that when you understand the results of trials, you have to take in context who was enrolled to these studies. So patients who went on to these studies were ones where their surgeons and their medical oncologists thought that it might be worthwhile to think about doing chemotherapy first before going to surgery. And in those cases, we see these equivalent outcomes. But we also know from historical data and from non-comparative studies that when we look at patients and they get their surgery first and they can get an R0, so no evidence of residual disease resection from surgery first, followed by chemotherapy, those are the patients who seem to do the best long-term with ovarian cancer. And so despite these results, I would also urge everybody to understand that it's really, really important to have a gynecologic oncologist involved in the decision-making regarding whether to go forward with a primary cytoreductive surgery versus whether to do neoadjuvant chemotherapy in your patients with newly diagnosed advanced ovarian cancer. The next question is intraperitoneal chemotherapy. And this is a question we've been sort of exploring for decades now. Intraperitoneal chemotherapy is chemotherapy that's delivered directly into the abdominal space. And the hypothesis behind this is that you'll get higher concentration of drug delivery to the cells in the abdominal space. In 2006, some of you may remember that the NCI issued an alert stating that intraperitoneal chemotherapy should be considered the preferred regimen for treatment for women with stage 3 ovarian cancer who had had an optimal cytoreductive surgery. Why was that? Well, we had this study called GOG 172, which was published in 2006, which showed this really significant progression-free survival and overall survival of IVIP, so intraperitoneal chemotherapy, compared to traditional IV chemotherapy. You can see here the Kaplan-Meier curves for progression-free survival and overall survival, with the PFS difference of about 5 months of IP chemotherapy versus IV chemotherapy, and an OS difference actually going towards 16 months in these patients. And so, of course, there was a lot of enthusiasm that we were getting truly better outcomes with this, and this was the first randomized phase 3 trial in ovarian cancer, newly diagnosed, that showed a survival that was exceeding 5 years on median. But despite this data, it turned out, and the NCI's recommendations, it turns out that the uptake of IVIP chemo remained limited despite this OS advantage. This is work done that was looked at retrospectively at what did we do after these data came out. And you can see here that, as we sort of had this uptake, you can see 2006 was the recommendation, and then there's an uptake, maybe peaks around 50, 55%, and then just sort of tapers off a little bit again. And even though retrospectively we could see that patients who got IP chemotherapy did better over time compared to those who did not, we weren't really doing it a lot. And some of that is because there are definitely toxicities associated with IP chemotherapy. Older patients sometimes have a harder time with it. There's neuropathy. There's technical issues about the amount of time it takes. People need to be trained in it. An IP port has to be placed. And also that patients were getting neuropathy that might be down the road. So these were all things that may have limited the uptake. And then this was followed by the results of GOG 252, which was a confirmatory trial that we did to try and validate the value of IP chemotherapy. This was a 3-arm trial. The control arm was carboplatin with weekly paclitaxel. There were 2 intraperitoneal arms. One was with carboplatin, one was with cisplatin. All of these arms included bevacizumab. A number of patients crossed over to IV chemotherapy from both of the IP arms, and this again reflects potentially the side effects and the toxicity that we see with IP chemotherapy. 30% of patients discontinued bevacizumab before cycle 6 on the IP cisplatin arm, again reflecting potentially the toxicity of these regimens. But really the take home is that you can see here the curves completely overlapping. These are actually the PFS curves, but the OS curves were also overlapping. So no benefit seen to PFS, and that really dampened the enthusiasm from IP chemotherapy. When we look at this as a whole, you can see these initial studies, the SWOG study, the GOG 114, the GOG 172 study, all showing sort of a trend or an overall survival benefit, but then followed by the GOG 252 study showing equivalent median progression-free survival, median OS that was the same. What do we do with this? I think that we recognize that we have different treatments now for ovarian cancer than we once did, and so it's not as sort of black and white as it once was. That being said, I would say that IVIP chemotherapy can still be considered for certain select patients, younger patients, ones where you're less worried about the potential toxicity profile, ones who have optimally cytoreduced stage 3 disease, but it's no longer sort of are considered the preferred adjuvant regimen for most patients. What about heated intraperitoneal chemotherapy? So a different way of giving peritoneal chemotherapy at the time of interval cytoreductive surgery. There was a phase 3 trial that was done in Europe looking at 245 individuals with stage 3 ovarian cancer who got neoadjuvant chemotherapy and were going for that interval cytoreductive surgery. You can see here to the right the overall survival Kaplan-Meier curves, but the PFS and OS both showed advantages of doing intraperitoneal chemotherapy, but there was no difference in adverse events and no impact on subsequent chemotherapy. This remains an open question. There are some centers that have taken this up, others that have not, and I think we're all trying to understand how much we can get by doing HIPEC and whether or not it needs to be cisplatin and things like that. There is a trial, GOG 3068, the HOT trial, that's a planned to be coming up. It's examining HIPEC in a US-based population and hopefully will help us understand better whether or not HIPEC should come into the treatment of these patients. Moving on now to maintenance therapy. I'm going to start out by talking about bevacizumab, but just a history of maintenance therapy in the field. So we have done a number of trials of maintenance therapy. We started out with maintenance paclitaxel, 12 versus 3 months, and we saw PFS improvement by doing 12 months of paclitaxel versus 3. Then we did surveillance versus 12 months of paclitaxel versus 12 cycles of a separate formulation of paclitaxel in patients who are in clinical complete response. And again, we saw median progression-free survival with maintenance therapy with paclitaxel, but no OS difference. And then we had another study where we used a pill, pazopanib is an oral TKI, tyrosine kinase inhibitor that has VEGF activity, and again saw median progression-free survival, but no OS benefit. And yet some of you may be asking yourselves, well, I've never seen any of these things come into clinical use as a standard of care, and that's because they didn't. Why is that? Well, when we think about maintenance therapy, I think one of the questions we have to ask ourselves is, what is it that makes a good maintenance therapy? And I think that if we talk to our patients and we think about it, one of the things is that they've got to be well tolerated. So doing another 12 months of chemo or another 12 cycles of chemotherapy without getting overall survival benefit, it means you're doing another 12 months of chemotherapy. And so that didn't seem very acceptable for many patients. We also have to have a meaningful benefit. And then it is a question for us, what is a meaningful benefit? And that's, I think, a question that, as I talk about some of our newer maintenance therapy data, is something to consider. We know that when we add bevacizumab to chemotherapy, it extends progression-free survival in newly diagnosed ovarian cancer. These are the results from the GOG 218 and ICON 7 studies. These have led to the approval of bevacizumab together with chemotherapy in newly diagnosed ovarian cancer. You can see here GOG 218 had a design where there were 3 arms. Carboplatin and paclitaxel was the control. Carboplatin and paclitaxel with bevacizumab, followed by no further maintenance therapy, was the second arm. And the last arm was carboplatin, paclitaxel, and bevacizumab, followed by bevacizumab maintenance therapy. And as you can see here from the Kaplan-Meier curves and the estimate here, 14.1 months was the carboplatin, paclitaxel, bevacizumab, followed by bevacizumab maintenance. 10.3 months was the control arm. And so somewhere around almost a 4-month PFS benefit. In ICON 7, this was a study that looked at carboplatin and paclitaxel versus carboplatin, paclitaxel, and bevacizumab, followed by bevacizumab. That, again, you saw a slight 2-month progression-free survival benefit. But as patients came off of bevacizumab, the curves start to converge. We asked ourselves, did certain populations benefit more from bevacizumab? 2 to 4 months for some people doesn't feel like a lot of progression-free survival advantage. And we did not see OS advantage to these. So we looked in what we called high-risk patients. In ICON 7, these were defined as patients with stage 4 disease or inoperable stage 3 or sometimes suboptimally debulked stage 3 disease. And you can see here in this curve here that the separation of the curves, you see a little bit. GOG 218 looked in patients with stage 4 disease, and I apologize, this does not project very well, but you can see here it's about 42 months for those patients getting carboplatin, paclitaxel, bevacizumab, followed by bevacizumab maintenance, versus about 32 to 34 months in the other 2 arms. How do we make decisions about who gets bevacizumab? These are the things I would say you have to sort of keep in mind as you're talking with your patient. All of the trials have a consistent, but it's a small PFS benefit, somewhere around 2 to 4 months. There's no overall survival benefit in the overall population. So what we're discussing with patients is a slight improvement in PFS. There's possibly an OS benefit in select high-risk populations, but these are subset analyses, have to be interpreted with caution. And then, finally, I think when you're thinking about it, it's sort of, are we benefiting the patients? Patients who have a lot of ascites, a lot of pleural effusions, bevacizumab can generate a faster response, and so sometimes those are the patients where you might get a lot more bang for your buck by adding bevacizumab in that time frame. Moving on to another type of maintenance therapy, PARP inhibitor maintenance therapy. So PARP inhibitors, of course, are drugs that have now come broadly into the oncology space in tumors that have DNA damage deficiencies. The underlying philosophy and hypothesis about PARP inhibitors is shown here on this slide. When we think about DNA damage repair, PARP inhibitors, PARP is a big player in base excision repair, which it repairs single-strand DNA breaks. Homologous recombination is a big part of double-strand break repair. And so we think about these as both important pathways for DNA damage repair. If you have a PARP inhibitor and you block base excision repair, those single-strand breaks convert into double-strand breaks. Cells that have intact homologous recombination, so homologous recombination proficient cells, still can repair those double-strand breaks, they do fine. But cells that do not have intact homologous recombination, for example, they're missing BRCA1 or BRCA2, those cells now get into trouble, they do not repair their DNA, and that leads to cellular death. That's the original hypothesis. We've since learned that PARP inhibitors work by a myriad of other mechanisms, including PARP trapping, as well as their direct effects on PARP1. And so we know that it's more complicated, as it always is, than we first thought. But we know that HR deficiency, the ability to repair those double-strand DNA breaks, is a big part of how PARP inhibitors work. When we think about our frontline PARP inhibitor maintenance trials, we have now had a number of them. I'm going to divide them in a little bit by sort of whether or not patients are receiving bevacizumab and then by the molecular characteristics. These are 4 trials that have been done in patients not receiving bevacizumab. SOLO-1 is a trial that was done only in patients with BRCA mutated tumors. The other 3 trials are done in all comers with a hierarchical analysis plan. PRIME-E, which is this trial in the middle, was done predominantly in China, whereas PRIMA and Athena Mono were done in Europe and in the US and in more Caucasian populations. Regardless, you can see across all of these trials, these are positive trials, hazard ratios that are well below 1, and you see here the median PFS estimates meeting their primary endpoint of progression-free survival improvement. When we break these down, I think it's really important first to think about our patients with a BRCA mutation, either somatic, so tumor only, or inherited in one specific category. These are patients who have not received bevacizumab but do have a BRCA mutation. And as you can see across all 3 trials, SOLO-1, PRIMA, Athena Mono, these are very active agents, hazard ratios 0.3 to 0.4, 2 years of maintenance if it's olaparib or rucaparib, 3 years if it is niraparib. When we look long term, and these data were presented last year and then published in the JCO, olaparib maintenance demonstrates long-term benefit in individuals with BRCA mutated ovarian cancers. This is 7 years of follow-up from the SOLO-1 data. You can see here the overall survival here is really impressive, a median overall survival not reached in the intervention arm, patients who got olaparib maintenance versus 75.2 months in those who did not. Really impressively, I also think, is when we think about time to first subsequent therapy. So this is not exactly the same as progression-free survival, but it's kind of a surrogate, right? If somebody has cancer that comes back, that's when you put them back on put them on another therapy. So time to first subsequent therapy, you can see 2 years, which is this dotted line that I've just put up here, is when patients stop their PARP inhibitor. And subsequent to that, 7 years out, you can see that 20% of patients who are on the placebo arm, their cancer did not come back, or I shouldn't say did not come back, they had not gone to a first subsequent therapy, but 45.3% of patients getting olaparib and that had not yet started on another subsequent therapy. It suggests we may be actually changing the natural history of ovarian cancer by giving PARP inhibitors in women with BRCA mutated ovarian cancer. So it's really important when you have a patient who has a newly diagnosed ovarian cancer, test for BRCA, and if there is a BRCA mutation, really consider, it's really important to give them a PARP inhibitor if they are able to get one. Okay, what about patients who don't have a BRCA mutation? So we've also looked at this. One of the things that we think about, I've told you that when we think about about these high-grade serous ovarian cancers, about 50% of them don't have that ability to repair double-strand breaks in DNA, so they're HRD deficient or maybe HRD test positive. When we divide them up, you can see that you have these patients that can be tested, HRD test positive, HRD test negative. And as we look at this in the PRIMA and the Athena Mono studies, we can see there is a little bit of difference of activity of PARP inhibitor maintenance in these populations. For the HRD test positive populations, you have a hazard ratio about 0.5. The median PFS and point estimates looks more generous. For those patients with HRD test negative tumors, the hazard ratio is still 0.68, 0.65, but if you look at those median PFS estimates, they are not as large, maybe around 3 months. Here is where the decision-making and the discussions with the patients are really important about what they are gaining from a PARP inhibitor maintenance, what they are not if they do not have a BRCA mutation. What is homologous recombination deficiency testing? So homologous recombination, as I've mentioned, is one of those primary pathways by which cells repair double-strand DNA breaks. It's a state where the cell cannot perform homologous recombination, but that's a state. How do we measure it? All of our tests of homologous recombination currently that are available are proxy measures. They use patterns of DNA damage to indirectly predict whether a cell is HR deficient or proficient. The terminology is still evolving. You might see this called HRD test positive or HRD test negative. And these are the assays of HRD on the right, the right-hand side of this slide, that have been used in ovarian cancer in phase 3 studies. So these are the ones you might see. Just remember, these are proxy measures, they're not absolutes. When we think about HRD testing, where else is it really important? If your patient is already started on bevacizumab, so you'll plan to continue them on bevacizumab maintenance afterwards, there is one study that has looked at adding PARP inhibitor to bevacizumab maintenance in women with newly diagnosed ovarian cancer. This is the PALO-1 study. These are the results from progression-free survival for this study. So as you might expect, those patients with BRCA mutations still have significant benefit. This is still the same, similar to what we see when they do not have bevacizumab. This has a ratio of 0.31. Patients who have BRCA wild type tumors but are HRD test positive, so have HR deficiency, that hazard ratio is also still less than 1 and looks quite good. But for patients who have HR proficient disease without a BRCA mutation, you can see that these curves overlap. These patients are not benefiting from the addition of PARP inhibitor to bevacizumab. So these are those hazard ratios. This is not a place where you add PARP inhibitor if your patient is already on bevacizumab and they have a BRCA wild type tumor that's HRD test negative, or otherwise known as HR proficient. These are the final OS follow-up for the PALO-1 and BRCA mutated and BRCA wild type but HR deficient ovarian cancers. And again, you can see here for patients with a BRCA mutated tumor, we see suggestion of OS benefit, 75.2 months versus 57.3 months. Whereas those patients with an HRD test positive, there is a suggestion that maybe these curves will separate, but this is not statistically significant. That hazard ratio is 1.13. We have not shown that adding PARP inhibitors, even for these patients, is benefiting them in terms of long-term overall survival. How do you make decisions around that first-line PARP inhibitor maintenance in advanced ovarian cancer? So, as you may have heard, recommended for patients with BRCA mutated germline or somatic tumors. There's significant BFS benefit. There's improved OS both in the presence or absence of bevacizumab. This is a can't miss. You gotta think about it for these patients. Consider HRD testing for patients with BRCA non-mutated tumors. It can give information for shared decision-making regarding PARP inhibitor maintenance. How much benefit might your patient expect from this? We are waiting for OS data from these large trials for our patients with BRCA wild-type tumors. Patients with an HR proficient or HRD test negative tumor should not get PARP inhibitor maintenance if they're already receiving bevacizumab. We've shown there's not a benefit to that. If you think about how long to treat them with PARP inhibitors, 2 years for olaparib or rucaparib, 3 years for niraparib. This is how the studies were done. There's not an indication to continue your patient who is in response on PARP inhibitors for longer than that. There are risks of getting MDS or AML that we have seen in our recurrent studies. Moving on to recurrent ovarian cancer, what's the state that we're in now? So unfortunately, despite all of our advances in the frontline space, we do know that the majority of patients with advanced stage ovarian cancer at this point will recur. Recurrences in the United States are most often detected by a rising CA-125, and we define these recurrences by the time since the initial platinum-based chemotherapy. If it's platinum refractory, that's somebody who really didn't respond to platinum, so their cancer is growing while they're getting platinum. Platinum resistance, we say that is recurrence within 6 months of finishing that last platinum-based therapy, and platinum sensitive is recurrence more than 6 months after last platinum-based therapy. It's important to recognize that platinum sensitivity is a spectrum. It's not that somebody took a line at 6 months and just drew through it and says that this is like a door you pass through. It's really a spectrum as we go. What are the specific considerations for recurrent disease? I want to talk a little bit about bevacizumab in conjunction with chemotherapy in that setting. I want to talk about PARP inhibitors again for recurrence or maintenance therapy. There have been changing indications over the past year, which many of you may be aware of. And then excitingly, there has been a new approval in the past year of mirvetuximab soravtansine, the first antibody drug conjugate that has come for treatment in the recurrent ovarian cancer space. These are the recommended therapies for recurrent ovarian cancer from the NCCN clinical practice guidelines. These are the preferred agents. As you can see, we do divide these by platinum sensitive and platinum resistant disease, and there are a number of potential options here. But how do we decide between them? We think a lot actually about what are the toxicities from prior therapies. I think about, is it a CA-125 marker elevation only? Does a patient have symptoms? Because that may move you towards something that is less aggressive in terms of side effects, because you're trying to maintain the patient's quality of life. Always think about the availability of clinical trials and the suitability for clinical trials for patients. We want to offer these patients as many clinical trial opportunities as we can. Patient convenience and choice plays into this. And then platinum sensitivity, as I mentioned, platinum-based regimens are typically not used for primary platinum refractory cancers. Platinum-based doublets are not clearly beneficial in platinum-resistant cancers, but again, platinum sensitivity is a spectrum. These are not absolutes, but these are things to consider. Patients do develop allergies to our chemotherapy drugs, paclitaxel or platinum, and this may influence how you think about treating them. And finally, with the approval of mirvetuximab soravtansine, the expression of folate receptor alpha or FOLR1 on the tumor becomes an important differentiating point for thinking about options that are available. So a word about bevacizumab. We know that bevacizumab added to platinum-based chemotherapy improves progression-free survival in platinum-sensitive recurrent ovarian cancer. These two trials were the first of our large randomized phase 3 trials to demonstrate this. To the left-hand side is the OCEANS trial of carboplatin and gemcitabine plus bevacizumab versus carboplatin gemcitabine alone. To the right is the GOG 213 trial, which was predominantly carboplatin and paclitaxel versus carboplatin and paclitaxel with bevacizumab, followed by bevacizumab maintenance. You can see in both of these trials the improvement in median progression-free survival, somewhere between 2 and 4 months, but the overall survival was not improved in OCEANS, and there was a trend towards overall survival benefit in GOG 213. There, sort of the p-value hovers on one side or the other of 0.05, depending upon some variations in terms of how the stratification factors are looked at. Since then, we've had additional trials that have looked at this. You can see here the ENGOT-OV18 trial actually looked at carboplatin, liposomal doxorubicin, and bevacizumab, followed by bevacizumab maintenance. I know that many people in the US think about carboplatin and gemcitabine and carboplatin and paclitaxel, but we actually have evidence that carboplatin, liposomal doxorubicin, and bevacizumab can be given and is effective in patients with recurrent platinum-sensitive ovarian cancer. You can see this is compared to carboplatin and gemcitabine, and the PFS and OS are not significantly different. And then the MITO-16B or ENGOT-OV17 trial was interesting because it looked at patients who had previously received bevacizumab and looked at adding bevacizumab to chemotherapy in the platinum-sensitive recurrent setting versus chemotherapy alone, and again, showed this PFS benefit. What do we learn from this? We learned that we can re-challenge with bevacizumab again and still get benefit in patients who have already previously received bevacizumab. We also know that you can add bevacizumab to chemotherapy for our patients with platinum-resistant ovarian cancer. And these are data from the Aurelia study where we looked at chemotherapy versus chemotherapy plus bevacizumab, physician's choice chemotherapy of liposomal doxorubicin, weekly paclitaxel, or topotecan. Here you can see the overall results. The objective response rate was improved 27.3% versus 11.8%, a PFS of 6.7 months versus 3.4 months. A lot of this benefit was driven by the combination with weekly paclitaxel, and so you will hear that people prefer to give weekly paclitaxel with bevacizumab. Recognize again that this is a subset analysis, so we don't, these are sort of not absolutes and was not statistically designed to study this, but this is a regimen that many of us will consider for patients with recurrent platinum-resistant ovarian cancer. Importantly, one of the things that we saw was that patient-reported quality of life outcome benefit was seen in those patients who had pre-existing abdominal symptoms, again, suggesting that adding bevacizumab plus chemotherapy could help patients in this setting. Now moving on to PARP inhibitors, and this has been a very fluid space over the past few months. These are the initial trials of PARP inhibitors in platinum-sensitive maintenance therapy. So study 19 was an early phase 2 trial. Solo 2 was in patients with BRCA-mutated tumors. And then NOVA and Ariel 3 were in all comers. And again, all of these trials were positive, especially in patients with BRCA-mutated tumors. I'm sorry, this I think is the patients with BRCA mutations. Based upon this, niraparib and olaparib were approved for maintenance therapy following platinum response in platinum-sensitive ovarian cancer in 2017. Rucaparib was approved for maintenance therapy following platinum response in platinum-sensitive ovarian cancer in 2018. When we look at this, in patients with a BRCA mutation, similar to the frontline setting, we see that these patients have significant benefit from PARP inhibitor maintenance if they're PARP inhibitor naive. We do not know what happens if they have already had a PARP inhibitor. So, this is very specific to patients who have never received a PARP inhibitor, who have a BRCA mutation. Hopefully you're not seeing a lot of them because we're treating them all in the frontline setting. You can see there those hazard ratios. Where it has gotten, and this is the OS data from it, you can see these are maybe a little bit sort of different than when we see in the frontline setting. There's a suggestion of OS benefit. This is a clinically significant difference, but not statistically significant in the Solo 2 study. And then in the subsets from the NOVA study and the Ariel 3 study, again from patients with BRCA mutated subsets, you don't see the same separation of these OS curves. Again, important that we're treating our patients with BRCA mutations in the frontline setting. That is probably where they are going to get the most benefit. When we come to our patients with BRCA wild type tumors, it has gotten a little bit messier. So these are the patients with HR deficient or HR proficient disease, HRD test positive, HRD test negative, in NOVA and Ariel 3. This is niraparib, this was rucaparib. And you can see here that in those initial studies, again, we saw benefit across these populations, hazard ratios in the 0.4 to 0.6 range. But then when we came to our OS endpoints, so these are new data that came out, these are secondary endpoints for which these studies were not statistically designed. We see that these OS curves start to overlap, but the hazard ratios, there were estimates where the hazard ratios started to exceed 1. And based upon these concerns, the FDA went to the manufacturers of these drugs and expressed concern about whether or not some of these patients could be getting harm from maintenance PARP inhibitor in this setting. In November and December of last year, the manufacturers announced withdrawals of their two lines or higher maintenance indications for niraparib and rucaparib as maintenance in platinum-sensitive ovarian cancer. That is why you saw the withdrawals. It is really, again, really important to remember these are subset retrospective, they're not subset, I'm sorry. These are, well, they are subset. They're subset retrospective non-analytical analyses. And so these are hypothesis generating. They don't prove that PARP inhibitors are bad in this setting, but they raise that question, and that was the basis on which these withdrawals were made. What about primary recurrence therapy? Where PARP inhibitors were first approved was actually olaparib as treatment for patients with BRCA mutations and recurrent ovarian cancer. There were 2 studies that looked at PARP inhibitors versus chemotherapy, the Solo 3 study and the Ariel 4 study, one with olaparib, one with rucaparib. And what you can see from these results that PARP inhibitors as primary recurrence therapy demonstrated a PFS benefit. So you can see here from Solo 3 and Ariel 4, both as PFS benefit compared to standard chemotherapy options. But when we looked at overall survival, again, there was not an OS benefit in Solo 3, and in Ariel 4, there was a trend, a hazard ratio of 1.3, and there were concerns about that as well. When we look in the recurrent setting further in Solo 3, there was a possible detriment in these patients who had 3 or more prior lines who had a BRCA mutation. And again, this was the approval that olaparib had for recurrence therapy in the US. And so then based upon these data, rucaparib, olaparib, and then subsequently niraparib were all withdrawn for the treatment of recurrent BRCA mutated or HRD test positive ovarian cancer. So these are just, again, showing you why these withdrawals happen. Remember, again, non-analytical endpoints, but having this question that was raised. Also important to remember, these are in the recurrent setting. Different than the frontline setting, the data that we see here cannot be extrapolated to what will happen in the frontline setting. We must see the OS data mature for the patients with BRCA wild-type disease. Ending on a positive note, we do now have a novel therapy for recurrent platinum-resistant ovarian cancer, mirvetuximab soravtansine. This is an antibody-drug conjugate that targets folate receptor alpha, or FOLR1. The payload is DM4. It's an antitubulin agent. And we saw in early trials, of phase 1 trials, the single-agent activity. Seen here is the data from the phase 1 trial. Here was a patient with significant liver metastases who had a good response after 6 cycles of this therapy. This was tested in a phase 3 trial called Forward-1, mirvetuximab versus investigators' choice chemotherapy in platinum-resistant ovarian cancer. All these patients had to have folate receptor alpha tumors, positive tumors, 1 to 3 prior therapies, mirvetuximab versus investigators' choice, and it was a primary endpoint of PFS. As you see here, mirvetuximab, disappointingly for us in the GYN-onc community, did not improve PFS versus investigators' choice chemotherapy in this trial. This is the intention to treat analysis. You can see the Kaplan-Meier curves completely overlapping. Underneath the folate receptor alpha high tumors even, maybe there's a little bit of separation, but it was not statistically significant. Why was that? Well, there was an analysis done that looked back at mirvetuximab and the data in this trial and looked at the scoring of folate receptor alpha testing. In the initial phase 1 studies, there was a testing for folate receptor alpha that was called PS2+ testing. And you can see here, Forward-1 used a different scoring system called 10X. Here you can see the 10X testing. These were the patients who went on the trial who were considered folate receptor alpha medium or high. But when you use PS2 testing, 2+ testing, about a third of those patients would not have qualified to have enough folate receptor alpha expression on their cells and would not have qualified for the trial. In a retrospective analysis, so very exploratory, they saw that if you looked at those patients who were folate receptor alpha high by PS2+, there was a difference in terms of PFS benefit, and this led to additional development. The SORAYA trial, which is a single-arm trial of mirvetuximab soravtansine in folate receptor alpha high patients by the PS2+ testing in platinum-resistant ovarian cancer, was presented and published last year, and this year, overall response rate of 32.4% in patients with platinum-resistant cancer across 1 to 2 lines or 3 lines of therapy, and somewhat agnostic to whether or not the patients had prior exposure to PARP inhibitor, which is important in our population nowadays. Based upon these data, the FDA granted accelerated approval of mirvetuximab in platinum-resistant ovarian cancer on November 14th, 2022. Now, it is important when you're starting to think about mirvetuximab, it's a new drug in the space, to think about the side effects. We definitely do see peripheral neuropathy with this drug, so it's something to keep in mind. And then very importantly are the ocular side effects. So a large percentage of patients, in blue is mirvetuximab compared to chemotherapy in the pink lines. You can see blurred vision, keratopathy, dry eyes. This is a black box warning for ocular toxicities with mirvetuximab in the FDA package label. There are very clear guidelines about monitoring and supportive care instructions that must be followed. Importantly, these ocular toxicities are reversible. So if you manage, they will reverse. You can dose reduce, but it's just important to have those in mind. In summary, when we're thinking about newly diagnosed advanced stage ovarian, fallopian tube, and primary peritoneal cancer now, evaluation by a gynecologic oncologist is super important. This is highly recommended. Germline and somatic testing for BRCA1 and 2 mutations is also really important. These are can't miss things, both for cascade testing and thinking about PARP inhibitor maintenance. There's significant decisions in initial management include the timing of surgery. Are we doing primary cytoreduction versus neoadjuvant chemotherapy and interval cytoreduction? What's the type of chemotherapy regimen you'll give? Is it IV chemotherapy? Is it IPIV in certain patients? Is it HIPEC? Is there a role for HIPEC? Are you going to include bevacizumab in the treatment regimen? A decision that's made oftentimes by the clinical presentation. Do we use PARP inhibitor maintenance? Absolutely, for patients with BRCA mutations. For patients without BRCA mutations, HRD status testing could give us some information about how much are you going to get, how much bang do we get for our buck. What about our considerations for recurrent disease? The decisions regarding what therapy you'll use in this setting are guided by toxicities, the patient preferences, platinum sensitivity. Definitely, bevacizumab can be added to chemotherapy as a therapeutic option. And then importantly, mirvetuximab soravtansine provides a novel therapeutic option for patients with folate receptor alpha or FOLR1 high tumors. Please remember to test your patients. I really appreciate the opportunity to update everybody here and all the members of NCCN on ovarian cancer in 2023. Thank you so much.
Thank you very much for this outstanding presentation, Dr. Liu. It's now time to answer some audience questions. You can use the questions button in the conference virtual platform or come up to the microphone to ask your questions. We have several questions, and one of them is, when is it the best time to order a comprehensive genomic panel for ovarian cancer, at diagnosis or at recurrence?
This is a great question. Some of it depends upon resources. At our institution, we do order our comprehensive genomic panel at the time of diagnosis. It provides us information. Oftentimes, the comprehensive genomic panels will encompass your BRCA1, your BRCA2, and other things. They're all at once. If you do an isolated testing for BRCA1 or BRCA2, you'll have that information, but you may need that information, all the other information in the future, should the patient recur.
And a follow-up or continuation with the FR alpha, are you going back and testing if already with a molecular profile, or waiting until progression?
For the patients with FOLR1 testing, in general, we've been not going back and testing everybody from who's ever been diagnosed. Patients who have recurrent disease, if you are concerned that they may be progressing on their current regimen, I am starting to test those patients now because we know that most patients will eventually develop platinum resistance. The testing has been, when you go through the testing is relatively rapid to get those results, but you do have to get the pathology from your pathology center, and sometimes that turnaround can take a few weeks, if not longer, and so that's one of the reasons to think prospectively about testing people so that you kind of know what your options are should they progress on their current therapy.
Excellent. For patients with BRCA mutation that progress within 6 months of completion of maintenance PARP inhibitors, do you re-challenge, and would you continue treatment indefinitely until further progression?
So this is a question that we actually don't have an answer for. We know that there's a trial called the OREO study where patients who had previously received a PARP inhibitor were randomized to and who then got chemotherapy, platinum-based chemotherapy, and had a response, were randomized to getting a PARP inhibitor again versus placebo. And there was a slight benefit, but it was not a very significant benefit. I think we have to understand, and this is a very important thing to think about, that patients develop resistance to PARP inhibitors. With patients with BRCA mutations, that can come in the form of reversion mutations. Patients who have reversion mutations, the likelihood they will respond again to PARP inhibitor by itself is not very high. And there is a clear risk with PARP inhibitors with prolonged exposure. If you look at our ARIEL-3 and our NOVA data, as well as our SOLO-2 data, the patients who have BRCA mutations who are on PARP inhibitors for a prolonged period of time, meaning 2 years or more, there appears to be a developing risk of MDS or AML that may be anywhere from 6% up to, in certain cases, in the ARIEL-3 subset data, it was as high as in the teens. This is not to say we should not give our patients with BRCA mutations PARP inhibitors, but I think we have to be very cognizant of the balance of risk and benefit and whether or not we're benefiting patients in that setting.
Excellent, thank you. From a classification perspective, is there any reason not to view peritoneal and fallopian as falling under the larger umbrella of ovarian cancer. Any difference in approach or treatment or other reasons to consider these as truly separate?
I think that when we're thinking about the high-grade serous histologies, we do consider them all under the same umbrella. It is probably the case that many high-grade serous ovarian cancers and many primary peritoneal serous ovarian cancer, serous cancers actually do have their origin in the fimbriae of the fallopian tube, and they're probably all biologically the same cancers. There are certain types of cancers that rise from endometriosis, for example, that probably are biologically a little bit different. And again, as we start thinking about these in different ways, we do have to think about the biology of the cancers, the underlying molecular profiles, and eventually I don't think we will necessarily treat all of these the same, but it's not going to be because of fallopian, ovarian, or primary peritoneal as sort of the labels for them.
Thank you. There's a question about how you decide to use IP therapy versus no IP therapy at this time in your decision process. And I'm thinking it's probably in the setting of maybe HIPEC at the time of interval debulking, because I don't think we are using cold IP up front anymore as adjuvant. So probably in the setting of interval debulking based on the VANDREAL data, what do you see should be done at this point?
So I will say that our center has not yet taken up HIPEC as a standard of care. I think we are looking to see more general confirmation of it. We do actually still sometimes use cold IP chemo in certain patients. We consider it in patients who have truly cytoreduced disease, R0 disease, who are young, who feel that they, when you talk about them about the potential risks and the increased toxicity profile, are willing and want to do it. There are some retrospective analyses from the IP papers that patients with BRCA mutations may get a little bit more benefit from intraperitoneal chemotherapy. You can imagine that if you have a cell that has HR deficiency, it is more vulnerable to platinum, and now you have even higher levels of local platinum delivery, so there's a scientific rationale for it. And sometimes we'll think about it for that setting, but recognizing that nobody really understands, can you make up for that by putting all those patients on PARP inhibitor maintenance?
Thank you. There are two questions asking the same thing. Does PARP inhibitor therapy make patients less likely to respond to chemotherapy in the future, or chemo-resistant?
This is a really good question. I think that what we have seen, so there have been a couple of publications which people may have seen where these are all retrospective, that patients who have had prior PARP inhibitors and then have progressed seem to have slightly less prolonged responses to platinum-based chemotherapy. And there are mechanisms of cross-resistance that are shared between PARP inhibitors and platinum. I don't think we should take these studies to interpret them and say that therefore PARP inhibitor is inducing platinum resistance, so much as that you may be over the course of using the PARP inhibitor, which is increasing the PFS, by the way, that you may be selecting out some of the clones that may be more liable to be platinum resistant. So when the cancer recurs and has seen prior PARP, that you've now selected out those clones. And so where previously you hadn't selected them, so the cancer would have responded to platinum, now in that same time frame, it is perhaps not going to respond as well. I don't think we have data that suggests that PARP inhibitors directly, however, induce chemotherapy resistance down the road, and this is an area I think we are starting to investigate and understand better. We do need better benchmarks to understand this.
Thank you. There's a question about advanced ovarian and uterine cancer, microsatellite stable, BRCA positive. Which therapy comes first between PARP inhibitors or pembrolizumab?
So in ovarian cancer, lenvatinib and pembrolizumab has not shown activity. It's not been studied the same way it is in endometrial cancer. In endometrial cancer, lenvatinib and pembrolizumab we know has clear activity, and actually in endometrial cancer, we don't have clear evidence of activity of PARP inhibitors at this point. So what I would say is that in ovarian cancer, PARP inhibitors are sort of, what has been demonstrated to have activity. We would not use len-pem outside of a clinical trial in general in these cancers. In endometrial cancers, we would not use PARP inhibitors in general outside of a clinical trial, but len-pem is a regimen that we know has demonstrated activity.
Is there a role for HER2 testing?
Currently in ovarian cancer, we do not see that the HER2-directed agents have shown substantial activity. We also know that the HER2 expression in ovarian cancer, there is probably some expression, but it is not quite the same amplification, the same way we see in breast cancers and certain types of endometrial cancers. As the new HER2-directed ADCs start coming of age, it may be that this will change and that we will want to start thinking about HER2 testing if we start seeing activity of HER2-directed ADCs or other HER2-directed therapies in ovarian cancer.
And the last question was about in BRCA1 patients, and it's not a chemo question, it's about if they are not at a point where they can undergo risk-reducing surgery, what surveillance strategy would be recommended, ultrasound, CA-125?
So I think that when we are surveilling these patients, we are doing ultrasounds, we are doing CA-125s, but I think we recognize that all of our studies that have looked at CA-125 and ultrasound surveillance in these women at high risk of developing ovarian cancer have not shown that these methods can effectively detect early ovarian cancer or fallopian tube cancer in a way that has an impact on mortality. And so we have to be very careful when we're counseling our patients that this is the surveillance strategy for them.
Thank you very much, Dr. Liu. This is all the time we have, and thank you for this informative session.